Operating Room Global TORG is a professional platform for operating theatre staff of all disciplines, both nationally and internationally. TORG was established in the year 2015, and currently we've got 25 chapters. Some of them are at registration stage. We have 89 countries represented in TORG, and we've got about 38 operating room specialties represented in the Operating Room Global TORG as well, nursing surgeon.
For TORG, accelerated innovation, better resource allocation, because sometimes there's a lot of wastage here. And so we need to learn the processes over there that's doing. Improve training and education, which I've passed on, enhance patient safety, data-driven decision-making, so we can still use data from somewhere else as well. Telepresence and remote assistance, and then personalized medicine. So uniting all of us, all these operating rooms can transform the surgical landscape, improving patient care and advancing the field of surgery. So I'm actually quite impressed that, and thank you for inviting me, and I'm impressed that this is going on. I know the CEO was saying there are some challenges, there will always be challenges in anything, but that resilience and that pushing ahead just tells you that you should not give up. This is going to grow because there is no country where they do not have surgery, where they do not have operating rooms. And for us in Lagos, in Nigeria as a whole, it's a plus plus. It's an advantage, it's a plus plus. So I really, really want to wish you all happy deliberation for the next 3 days. You know, the surgical unit is not going to be the operating unit without the nurses. We all know that. So kudos to you all. Keep up the good work. But you really have to change mindset when it comes to working in silos, which is what this thing is going to help as well, that you are doing this for the patient.
Can you please share your insight into the impact of ongoing training and professional development program on healthcare workers' satisfaction and retention? Something that will make them to be satisfied and to be retained in this country.
Because of the state of the country, this sort of pushes them out there to explore and get the desired money to meet their aspirations. The aspiration is to have a better working environment. The aspiration is to get more money because they believe that they are ready to same service and getting paid so little for it. But if they go out there, do the same service, they get more money. So one of the challenges we have is because of their personal drive to achieve more. And you cannot compete with that. The person's personal drive to achieve more, regardless of whatever environment it provides. Because they want to achieve more, they want to go to where they think they can achieve more. This is the African region, our own region. Whatever is happening all over the world, we must be interested in how things are supposed to be in our region, because we will survive. Conducting need assessment is the first. We want to know what are the needs in terms of skills, in terms of knowledge, in terms of specific areas, context-specific challenges, because what is happening in the federal health institutions are peculiar to federal health institutions. What is happening at the state level, what is happening at the local government levels, there are some things that are general and there are some things that are specific. And I want to say that all stakeholders need to carry out a quick need assessment. When we carry out this need assessment, then we are going to contextualize the content, and that content is going to show that we are adapting our solution to the environment where they need it most. And at this, we also need adaptation training programs to address these local health priorities. Assuming there are disease burdens that are, known to some areas compared to others, that is their own need, and that is what we're going to face at that particular time.
Then, let me say this again. Article 13 of the Universal Declaration of Human Rights says that everyone has the right to freedom of movement and residence within the borders of each state. And so everyone has the right to leave any country, including his own, and to return to his country without any hindrance. May I say this, that based on this, if you believe that somewhere is not okay for you, you have the right to move from that station to another one. Even within Lagos, just like my sister has just rightly said, that you can move from Lute to Lasut to General Hospital Ikeja, whichever area that you think people will accept you and you'll be able to perform your job without any hindrance.
There should be close monitoring. A lot of things are happening in our environment that is not known to a farmer. And that is the one. Secondly, concerning faith-based clinics, we need to look into that. People are actually dying. People are actually dying. Because I was at the DNS office concerning this, and it's only Lagos State that is actually giving monitoring. There are some areas that are borderlines. Ogun, Lagos, people in Ogun State are doing worse.
Leadership plays a big role, especially in Nigeria, a big role. And you're right, our leadership is trained, and it's not just nursing. Even anything that you're pointing, it's just not fair. You put somebody in a leadership position, and you don't train them, you don't equip them. You're very right. They will not be able to. That's why we have 4 leaders. It's not necessarily their fault. And another thing is the way we actually contact. We need to stop this. Not everybody is out to set up to do it. Not everybody wants to do it. I don't care if you're 16 or 17. It's not your turn if you're not a good leader or if you do not want to do it. Nobody should force it on. It should be through merit. What have you done? How do people see you? How do the juniors see you? Are you a good mentor? And all that. Because leadership is a whole lot. It is very difficult. Even those of us in leadership sometimes like, what the hell am I doing? And all that. But you know what? You enjoy working with people and managing people. So it's a big thing. So that's another thing. Not just nursing. So it's like, it's this person's turn. Okay, you are now the next chief or whatever. It shouldn't be like that.
I have just been shot. Our train is under attack. And what did Nigerians do? They told her, and you are here on Twitter, Chidi, you are not yet dead. Where's Dr. Chinedu today? She's dead. She didn't survive that. If you feel that the reason the young doctors and nurses are leaving Nigeria boils down to how much they earn, then we've not started realizing what is happening around us. The last person I spoke to before I left Abuja, his dad was kidnapped yesterday. And today, they sent him the picture of that day. He's the only one of all his siblings in Nigeria right now, but the others are in the US. Tell me what he will be doing in the next 3 months. Visa. There is one thing we can do. I was very happy to hear we have a regulatory body for practice of nurses in Lagos State and hospitals. But if you know the history of FRSC, you know it started from Ibadan. So you can think globally and act locally. Why don't we now find a way to now start drafting a new federal healthcare policy, relying on this institution already in Lagos as the foundation for its actions? We don't need to start drafting new guidelines. We will use this guideline, just inculcate. We don't need to start drafting new strategy, just inculcate and elaborate. Why don't we find a way to ensure that our doctors and nurses, pharmacists and lab practitioners are secured?
Let me conclude here that love is essential. You have to love ourselves, love our patients. Courage is so important. You have to be courageous to be able to achieve 1 or 2 things as nurses, as professionals.
And honor is great. You honor yourself and you give honor to whom honor is due. Thank you.
For that, we should always give due attention for clinical examination. Usually it's said in our clinical years, by the beginning of clinical years, we were told that history and physical examination will lead to around 90% of the diagnosis. But in clinical practice, when we have so many patients, we only focus on patient works. That's why I say beyond patient works, the role of physical examination and patient management. So as a conclusion, please, physicians, healthcare workers, do head-to-toe physical examination. And when you have masses, soft tissue masses always have high index of suspicion, especially in black race. It's not that common, so we need to have high index of suspicion. The other one is we should never assume that the patient may need the operation because we need. So we should always take written informed consent for every procedure we're taking. If we take written informed consent for the right, then we need to have for the left one.
So it means that decision makers here should go home with the mind that we need to be more sensitive to the individual needs of our individual patients. When there is a patient of a particular type, that's not when to insist on the roster that's been drawn up. You may want to alter the roster a bit for the sake of that patient and then do a balancing adjustment, readjustment, so that we can always work in favor of it's something we need to really think about and start working on. It's not so difficult, it's not rocket science. Once a patient has expressed a preference, let us do the best we can to respect that preference. Even if it's just for the sake of that patient. Then the next patient, then the next patient. Before you know it, word will go around that, that's hospital, they are very good. They respect the wishes and preferences of their patients. Is it easy administratively? No. Is it likely to inconvenience surgical workforce? Yes. But does that give us a better image to the general society? Yes, it does. And I think that's the bigger thing.
We feel very strongly that Africa is, will I say, underserved. There's so much to be done, but if you do not have the right place or the right market to sell it, you find that you're just, trying to reach people that are not wanting to be reached yet. UNICAF offers studies to study online. Online makes it, I would say, relatively easier for those of us, especially in this case, I would say women, who have families, who have jobs, who have so many other things that are taking time. These are all, equally valuable things and very, very important for a person's growth. But then you find that you want to get a master's degree, or you want to get a second bachelor's degree, or you want to get your PhD, and you are thinking, do I have to leave the family and travel? What do I do with my husband? What do I do with my children? What do I do with my current job? That's where UNICAF comes in. UNICAF says you can get that exact same value, you can get that same quality, nothing tampered with, from the comfort of your homes and your offices.
Minimum access surgery is a conspiracy against the poor people. Then some of us that were sleeping just woke up suddenly. Now, acceptance in African culture, in African setting. My experience is this. I've been doing minimum access surgery here in the country for 2016. My experience is this. The only deterrent, I'll just summarize that. The only deterrent to minimum access surgery among our people is the cost. Nobody wants a tummy to be cut open. Nobody wants to have an ugly scar. In fact, in the institution where I practice, the parents call in. If you cannot do laparoscopy for my daughter, don't operate her. You understand it? And it's surgery in our culture today it means a lot of things. So having that information that you can be operated and you still maintain your female bodily figure without scars is welcome to a lot of our people. However, the moment you introduce the cost to them, then they begin to give you excuses.
is there any stage cataract can get to that and no longer be operated? That is to say, there are forms of cataract can be operated.
Cataract is a condition where it actually depends on the patient. So the patient is their own doctors. They come to you when they can't see. So if I started doing a massive screening here, most likely I will find few have cataract. Okay? But not everyone needs a cataract surgery when they have cataract. So we can do a cataract surgery even if someone who doesn't have a cataract, they don't. But they don't want to wear glasses, for example. They have a clear lens, we remove that clear lens to put the prescription into their eye so they don't have to wear glasses. The cataract, if progressed badly, will be difficult for the surgeon to operate. So the surgery can be more difficult and more complications can happen. If it's not operated at all, we have a condition called glaucoma, which is a blinding condition where the pressure in the eye raises up. So if someone has a cataract, it becomes so bad, the lens swell, it will close the drainage system in their eye. They will develop glaucoma. They will go blind.
So every government comes to Nigeria or into African countries and start their own policies by themselves. Countries, because we want to prove to the world that we are better than the last person. Few weeks ago, I said we had ministers for 8 good years. The last regime, where we now have other ministers for the next 4 years. Did you have a proper handover note from the last minister to you to tell you these are the things we have done in the past? This one worked, this didn't work. How do we sustain it? What I realized is that everybody wants to outsmart the other person, and collaboration is not in their dictionary. That's why we are saying today, in our own small spaces, let's begin to do the right thing so that people up there can learn from us. If, for example, in the theater, I give you an example in the theater, your role is to know that Bible 2 sutures are not available. So your own role, it's not because it's you have to do it, because you want that the collaborative effort of that room, the operating room, is sorted. You will do what you expect to do. And that's why I love nurses a lot, because you always do handover. You are great people. I don't joke with nurses, because a nurse always hands over. So if a nurse hands over, why can't a minister also hand over?